Yes.
Amy? Yes.
Item 3, public comment. Anybody wishing to make public comment here at this time? Say none, we'll go to approval of the action items, and I'll ask for item Q to be removed separately. I need to abstain on that. Is there a motion to approve items A through U minus Q?
So moved.
There's a motion by Gray, is there a second?
Second.
Any questions on any of these items? Roll call.
Okay, Gray.
Yes.
Espinoza.
Yes.
Weiss.
Yes.
Rogers.
Yes.
King. Yes.
Item Q, agreement with Charles Drew Health Center for Omaha Healthy Start.
Motion approved.
A motion by Gray, is there a second?
Yes.
Second by Weiss. I need to abstain because of being on the board. Roll call.
Gray.
Yes.
Espinoza.
Yes.
Weiss.
Yes.
King. Yes. And Rogers
Abstain. We'll go now to issues with COVID. Dr. Ford.
Good morning, Board of Health. I feel like you are the traveling Board of Health. We are at a different site every time. And you know, that's not a bad idea. You may want to think as Board of Health if you want to start to be in different areas of the county so that people feel like you are their board, because that's what you are. So keep that in mind. So just, I'm going to give you some numbers, and then I'm going to have one of our fabulous staff really talk to you a little bit what is really going on behind the scenes, because the numbers are just the numbers, but there is a lot of work that is going into it. So I think you will be interested to hear from Justin Frederick. So as of yesterday, we have now tested 33% of Douglas County residents, and 20,323 have tested positive. So that is 3.6% of all the residents in Douglas County. And just to keep that in mind, that's a long way away from herd immunity. If you are thinking herd immunity, you sometimes talk about 50, 60, 70% of the population. So I just want to put that in perspective. Within the last 3 weeks, we have had 5,000 cases. And I do not need to tell you that last week we had 2 days where we had more than 300 cases a day. I thought I never would see that. And that's really quite disappointing and remarkable. However, last week also we tested more than 10,000 people in Douglas County. That's not the highest, but it is the second highest testing that has been done. And that's good. That means that people who potentially feel like they have been exposed or they have symptoms, they are going to go and get tested. So from that perspective. But we had the highest positives last week, 1,817 individuals. Compare that to the week before, that is 600 more positive cases than the week before. 2,000 of these tests, of these 10,000 tests that were being done, are antigen tests. And I just want to talk to you a little bit about this. We have a great opportunity in Douglas County because we have Total Wellness on 93rd and 8th, and they are providing antigen testing on a Sophia platform, it is called. You can sign up on the web and put in your insurance information. You get a QR code, you go to the site, you stay in your car, they test you. Within 20 minutes, they test you the results back. But I want to caution everyone, antigen testing is really best if it is used on individuals who are symptomatic or individuals who say that they have been exposed to somebody with symptoms. It's not for general surveillance yet because the sensitivity is lagging behind. But what we also saw last week is the highest positivity rate, 15%. And I'm saying the highest positivity rate because we had higher positivity rate in May, but then our testing was very critical only to those who had cases, whereby now the testing is much more open. So you would expect this. But last week we had a positivity rate of 15.4%. Age ranges, again, that age range that we see most of our cases are 20 to 59 years old. 70% of our cases are in that age group, 20 to 59. Really the highest is 20 to 29. Race and ethnicity, over the last 2 weeks, we saw that in our Asian population, 2% tested positive, African American 7%, Hispanic 17%, and white 64%. So we are starting to mirror what we see across the population in Douglas County. We have recovered 70.5% of our cases. So at this time, we have 5,989, potentially 6,000 people that still have neither not fully recovered or have just been diagnosed with the virus. I think that's important too. I think one of the most concerning information I share with you is the one that you hear about now, is our hospitalization in our Omaha area. And as of yesterday afternoon, we had 195 med-surg beds available. That is out of a total of 1,357 staffed beds, an occupancy rate of 86%. We had 64 adult ICU beds available, 81% occupancy, 10 pediatric ICU beds. But to me, the most important number is how many COVID patients do we have in our hospitals? Because hospitals want to be full. That's their goal. We had 179 COVID patients in our hospitals. 59 of them were in ICU units, and we had 29 PUI, person under investigation. They have received a COVID test. They don't have results back yet. So I thought about this hard last night, and I think the message is every fifth ICU bed is occupied by a COVID patient. Every fifth ICU bed. And every 10 hospital bed, general hospital bed, is occupied by a COVID patient. So that kind of gives you the proportion. And as you have heard, the governor is concerned together with all the local health departments to say, what do we really need to do about it? And in the DHM that is going to go in effect today, actually there is going to be a measure in there that the hospitals need to have 10% of their hospital beds and 10% of their ICU beds kept available, so if they need to be used. Otherwise, if they go above that, then actually elective surgery needs to be considered to be eliminated, or they actually need to have a plan, a capacity expansion plan in place. That's the other thing that hospitals can do. Talking about death, we have unfortunately 215 deaths in our community for a mortality rate of 1%. That's actually pretty low. 78.5% of those individuals, unfortunately, are 65 years or older. 65% are white, 14 are black, and 16 are Hispanics. Let me talk a little bit about schools. What are we seeing? Because now we have 6-7 weeks already. Some schools have been in place, and we are looking at data. The health department is, but also the superintendents. We are meeting with them regularly to see what are we seeing, what do we need to change potentially. So over the last 2 weeks, we have now 141 total cases in schools, 83 of them are in staff, and 58 of them are in students. We have 327 of individuals in quarantine. 88 of them are staff, 239 are students. So that means quarantine for 2 weeks. Potentially these students are going to go on remote learning then when they are in quarantine. We also have 668 individuals who are self-monitoring. That means they potentially had an exposure, but since they both were wearing masks, they can go back to school but self-monitor. We have 262 staff and 406 students. What our staff has looked at is what is the transmission that is occurring within the school. And what they have calculated is from the data we have, potentially 1.6% are class transmission. Very few. So what we are seeing is, because we have high case counts in the community, that's what's coming in. It's where individuals are getting infected. Long-term care facilities, I just want to talk a little bit about it. ICAP, the Infection Control Assessment and Promotion Program at the UNMC, has been working, with long-term care since the beginning. They actually went to those long-term care facilities, made recommendations, and once they have outbreaks, they actually make recommendations now too. And they just put a quick report together yesterday that said that in long-term care, from the beginning, we have 27.4 deaths per 1,000 residents. That is the 14th lowest in the nation. That is for the state of Nebraska, not just for Douglas County. And we have 106 cases per 1,000 residents, and that is the 11th lowest. So I think I want to give credit to really setting up these programs, and they were set up at the Global Center for Health Security at University of Nebraska Medicine. And we are seeing how important these programs are at this time. So I'm very thankful. This is the same group that also has gone to meatpacking plants and has really tried to see what measures are they putting in place, then went back and actually looked at the measures if they have worked. Now, just internally, a little bit of some of the programs. PPE, protective equipment, we have given out 5.4 million pieces. This is Douglas County. We have become a distribution center of 5.4 million pieces of PPE. I'm very proud of the people there. They've put together a great database and really are making the process very smooth so that healthcare facilities, long-term care, can come and pick up PPE. Our navigators, they get referrals. They are getting the referrals from our contact investigators, and they have potentially 22 to 28 referrals a day of people who say they have need for housing, for food, for transportation. Our info line, and I just need to do a shout out to, I need to do shout outs to every staff in our department. I want to share with the board, we have just great staff. And they are very trying times. And what we are seeing in the info line, but also I think Justin will tell you about on the contact tracer. People are getting more nasty on the phones. And so on the info line, they are starting to say we are concerned about the phone calls we are getting because people are not civil anymore. And I just want to say that is unacceptable. We are like a large family, and if somebody is doing something against us, it's not a good thing. But instead, or even so, these are hard times. We are now planning for what is going on over the holidays and how does our schedule need to look like in the info line. And I said to them, You just talk amongst yourself and you present me a schedule, and I'm good with it. I'm good with having days off. You have days off, and we close the information line over the holidays. You know what? They came back to me. They came back and they said, Dr. Poor, we can't do that. The community is dependent on us. We can have the info line closed one day, but we can't have it closed for 2 days. I tell you, it filled my heart to hear that. These are people, these are typical public servants who want to do the best for the community. So I just wanted to share that with you. Communication, I can't give enough credit to Phil and his group, what they are doing. Social media, for example, I heard just yesterday we had more than 730 likes on a video that we put out. We had 64% increase on our page use, Facebook page use. And we had 446% increase in engagement where people write back to us. Also, we have improved our dashboard. You know, as time goes on, you always learn and you see that you need to put other things on there because that's what we are. I want us to be transparent, want us to have enough information for the community so that they can make good decisions. Some people may like it. Some people are telling me they have like their own spreadsheets at home. They are looking at the dashboard every day and so on. So together with all local health directors across the state and with the governor, we have decided we are starting a new campaign called the 3 C's. The 3 C's means be really careful about crowded places, close contact, and confined spaces. So we are really trying to push that out because so many of us. It may be, do you need to go?
Say that again.
I think you need to.
Say that again, Dr.
Crowded places, close contact, confined spaces. So the other 2 activities that I just want to share with you are plan reviews. These are reviews of big gatherings. And we have reviewed up to now about 80 of these plans. And I just want to share also and give a compliment to the community. These plans are being put together very thoughtful. And our team is then reviewing them. There is some back and forth what needs to be included. We had a plan. I actually received some complaints about some sport activities. Got back to the organizers. They showed me their plan. Our team made some recommendations. They said, yes, we will include those. We will upgrade those plans. So a lot of back and forth going on there. And the last thing I just want to mention is mass vaccination. You know, a lot of work is going on behind the scenes. The state developed a plan, actually, and sent it in to the feds on Friday. A lot of provider enrollment is already occurring, meaning those people who are providing vaccine for children, they got an invitation to say, do you want to provide mass vaccinations? And if you do, there is some commitment that goes along with it. The plan also identified very specifically what some of the tiers of vaccinations are going to be, because we do know there will be limited supply, specifically at the beginning. And so our work is starting now to really try to say, how many of the healthcare workers do we have in our community? Because we have a lot of healthcare workers that come in from the outside. Healthcare workers that have direct access to COVID patients potentially would be in that phase 1A. They would really be the one who would have the option to get the vaccine first. Only those who have contact, not those who are remotely working at home or so on, but those who have direct contact with COVID patients. And then, of course, 1B is a much larger group, including long-term care facility workers, including also minority populations, individuals who were more vulnerable to COVID, who worked in environments where COVID was more likely transmitted. So that is going on. I think Carrie is our point person. She's starting also to order more equipment that we would need for mass vaccination in our community, and she's really the one in touch. What we don't know is what vaccine is going to be available come the end of this year potentially, is what cold chain is needed for that vaccine, how many doses need to be provided to that for that vaccine. So we'll move along with it as good as we can. That's really kind of the report I want to share with you in regards to the data on COVID. Any question? Yes, Dr. King.
You mentioned that you have made there were some improvements made to the dashboard. Can you talk a little bit about what those were?
Yeah, some of the improvements, the dashboard actually looks a little bit different right now because we have so much more data on the dashboard than we had in the beginning. So we have kind of clicks on top where you can go into different area like testing, cases, or so on. We have also included much more on hospitalization. We still have a lot of demographics on there, race, ethnicity, definitely we have left it on. So just to make it also a little bit more user-friendly. So please go on it, and if you have suggestion as a board, please let me know about it.
Or just for the record, what you did, what's the difference between onset date and confirmed date? I mean, what's the difference?
No,
onset tab. What's the difference between
collection date and date reported? Is that what you are talking about? Because that is one.
Cases by the week, but then it says confirmed case by onset date.
Okay, by onset date is the day by onset date?
Yeah, onset date. The tab that says onset date, it has two, but.
That may be a question you may want to ask Justin. I think one of the difference that you will see on the dashboard is we have tried to mirror some changes that the state has been doing. One of the changes, for example, is positivity rate by collection date. That's always how we have done it. And I still use that really to communicate to the community, because once I change, everybody thinks something funny is going on. So I don't want to bring that mistrust into the communities. But in addition, what the state has been doing, positivity rate by collection, you see, I'm even confusing myself. It's a positivity rate by date reported. That's when the laboratory is reporting the date to us. By collection date means we are going back, when did you go to the site and got your test taken? Potentially that is a better measure, because date reported depends on when the laboratory is reporting the data, is analyzing the data, and I tell you, some of the national labs, they do not report every day. They may report every 2 days or 3 days. But what the collection date does, data by collection date, it actually pushes it up a little bit, and it's really difficult to explain to the public why we are suddenly making this change. So I am staying in the information I'm giving to the date reported, data reported, that date we get it from the laboratory. So this was one of the bigger changes, and you see both on our website, and I felt very strongly that we needed to keep both on there. Yes, Dr. King.
There's been a lot of concern with the possibility that testing will be done in facilities that are outside of the lab, or going in and getting tested, and so people are concerned about the reporting error that might be. Is that a concern here in our county?
You know, the state and local health departments are working very diligently because now you do have these antigen tests available that clinics have. There are little apparatuses that they have in their clinic, and you know, it's good for them, but we need to have the data so that we know how many people were negative and how many were positive only. So the state epidemiology group is really working with these clinics and trying to say, okay, how can you send us this data on a daily basis, potentially on a spreadsheet, so that we have the data complete. Yeah.
Dr. Ford,
Yes.
2 questions on the COVID-19 vaccine. Will there be a cost for the public, and are the meatpacking employees part of Group 1?
Yes, meatpacking is falling under, I think, 1B, Tier B, because they are the ones working in a highly transmitted environment. And I think they let every community decide, dependent on data, what are those high infrastructure environments that really had a lot to do with COVID. So yes, I think meatpacking, especially for us, because our data was very clear how much transmission was occurring there. And your first question?
There's a cost for the vaccination.
A part?
Cost. Will people have to pay?
And
for
the
it?
cost you have to pay.
Oh, a cost? No, no cost. No cost at this time. And the federal government has been pretty good at this in saying there will not be a cost for the vaccine.
One last comment.
Yeah.
I just want to thank the health department, Carrie, Natalie, and Ivanka. They have helped me set up a flu vaccine clinic at the Latino Center. So we are serving that population. We had, 2 weeks ago, we had our first clinic, and we were able to vaccinate 160 people within 5 hours. And then we have a second clinic coming up next week. So I just want to thank them for all their work and their support to my community.
And that is a good example I forgot to share. You know, there are potentially 7 different sites where our team has gone out now and provide vaccination, provide flu shots. And to really, this was funded also by the state to actually encourage and see how does it work, how could we make it work easily. So I'm glad you shared that with us. Thank you.
Dr. Ford?
Yes.
And I know you talked about civility and the kinds of calls that the health department is getting. Next week, as you probably know, you, myself, and the city council are going to run the gauntlet again with another extension of the mask mandate. And this time that extension is going to run until December 29th. I've been considering, and council has been considering, including a metric in it so that, and the reason for that is so that we're not meeting every 2 weeks to extend the mandate and listening to all that vitriol and all of the stuff that has been going on the last couple of times we've done this. So I guess my question is there a metric that you would consider that would be that we could use that would be helpful to the council so that we're not doing this every couple of weeks?
So in regards to metrics, you know, we have had this discussion quite a bit. From the beginning, I have said 5% positivity rate. That would be one metrics. And then last time, Dr. Khan was saying, in addition to the 5% positivity rate, also 10 cases per 100,000 population. You know, 10 cases per 100,000 is a little bit high because we have heard 5 per 100,000 may be the right thing. So it's between 5 and 10 per 100,000. He put it out there as 10 per 100,000. And I do think if I would be down at 10 per 100,000, I think we would say we have some control in our community. We are now 10 cases per 100,000. We are now, as of yesterday, I think we are at 43 cases per 100,000. just to give you a perspective. Positivity rate, 5 would be good. We are at 15%.
I don't want you to be surprised that I may throw a metric in there as an amendment to it, so that we're not meeting every couple of weeks, we're not having public hearings to
Yeah.
extend the mask mandate. Trying to eliminate some of that anger that's out there.
Yeah, I agree with you. Thank you.
My second question, I have one more, I'm sorry, Mr. Chair, one more
No,
question.
go ahead.
Do we know, in terms of the overall rate of positivity, how much of that is community spread versus being in a confined environment?
Yeah, and I'm not sure if Justin is sharing any of that data, but most of it is community spread at this time. We have very few large gatherings where we would say, well, this is a super spreader event. We have, I think, must be around 30% of contacts, meaning if you are a contact to a positive, you are more likely to actually be infected. So contact is one of them. The other thing is just community spread overall. And what we are seeing, heard about it yesterday again, are these family gatherings. Gatherings where you suddenly bring in new people that they are not from your close family. And yesterday I heard a group of 10. One new cousin came in this group, and now we have 2 adults and 3 children are infected. So it goes very quickly. And that's when you are not wearing masks because you are around, you are in your home. And so we really, really need to be cautious as we go into fall and as we are going inside.
Kind of going back to the metric question, that is to reach those rates, let's say the 43 per 1,000 residents with the 5%, the 10 per 1,000 residents. Do you need to have that for like 2 weeks in a row?
Yes.
Or you just hit once and?
No, these metrics are always 7-day rolling averages.
7-day rolling average.
Yeah. Yeah, so at least for 7 days, so that you are spreading out and evening out the cases. And usually we like to see this over a longer period.
So, Dr. Porter, what's being talked about amongst the epidemiologists in respects to in May or June, people were estimating we roll out of this in November 2021. What's the estimated timeline talked about now? Is that still it?
Yeah, you hear a lot of talk and speculation about it, and I do think that's most of it speculation and hope. And I wouldn't. You hear a lot that potentially by the end of next year, this will really become like the flu, like something we are just accustomed to treating. Those are kind of what the information I hear from the epidemiologists. It's going to be next summer, next fall, when we really are able to hopefully mass vaccinate larger groups of people. That's when you are going to feel more comfortable because the vulnerable potentially can protect themselves. Also by that time, hopefully, we have some better treatment. We have good treatment, and remdesivir is one of them. And it really is shortening the hospital stay. I just looked at a study again yesterday, and that is all positive. But what we do want is we want to prevent people even from going to the hospital. That's really what we all are working on. And that's what the interest of the entire population should be. We want to do prevention. That's what public health is about.
Let me merge, trying to get at 2 questions. One, can you all do an estimate of what, budget-wise, ask Tim to do a run for the next meeting of what it will take to maintain the level of operations after December 30th when the money stops being able to use, just so we can be prepared because that rolls me into, I know there's talk about it, but have you and friends start laying out at least a framework or some things specifically for the legislative session to ask to get us post-pandemic? And if not, can we ask for that in December? Because I want the board to get a grip of that, because I think we're gonna put some strength behind having to get this done, and I wanna make sure that we know where we're going, because there's some tweaks that need to happen in the long session. I know people have been talking about it, and I think we gotta take advantage of it in this window, even if that means an all-out fight with the government.
Yeah.
Because I think some of the stuff we're seeing now, in regards to local control and being able to do some stuff, is probably gonna be looked at.
We are in discussion with that, and but no decisions have been made. In regards to funding, we also are asking that the governor all the time and saying, what's happening in January when potentially the CARES funds go away. He's very concerned about it, and he's saying, he will let us know. He hasn't heard anything from the feds neither, so.
What, can Tim do I need him to give us a budget about what he thinks the increase will be right now for us to be operating post-pandemic. Meaning, there's some things that are there now that are going to stay, that need to stay. And I actually need to feel that so every board can start making improvement.
Yeah.
I think that needs to be put out to Ethan now, because he, they can't go into the next session with the level of funding that they want to expect.
Yep. And Tim can do that. We have pretty good numbers what we are spending internally every month on COVID, but what are going to be additional expenditures in January if mass vaccination is going to go, and so we can provide that to you. You just reminded me, we are now hiring 2 additional people in epidemiology, one epidemiologist and one a disease investigator, due to funding that we have received from the state, additional funding for 2 years. So that's going to be helpful, because we need to strengthen our internal infrastructure. You can have, and the governor was announcing yesterday, we now have 1,000 contact tracers in Nebraska. But those are all, they are not internals, and they do not know the community as well as our staff does. So you have contact tracers in Lincoln, Nebraska, who contact trace for Kimball. It's very difficult for them to actually ask the right questions even to see. The same thing in our department. We are lucky in using PRC, who has our staff trained them very well, those contact tracers, but we need somebody who oversees it, who then makes these connections where people have been exposed to. So it's really important that we strengthen our infrastructure internally.
I wanted to clarify for your question. So you're asking Tim for a budget really for 2021, so past the current COVID CARES dollars?
Well, actually, 2 things. One, what's not used October, what's not used December 30th, technically things have to be used past that. Now, there's some conversations that I know the board's been having with people requesting CARES Act money. I know there's some extension a little bit, that my understanding on the clarity has been used. For instance, there's requests by some entities for HVAC systems to be done in entities where there's a lot of people. For instance, like a Metro Community College, things of that sort. I think there's some carryover that may allow them to finish this until March. But for things like the services and things like that, that's December 30th. And even though, so I know there's conversations Dr. Moore and I have had about, methods that we need to go at for this money for the money that's sitting for vaccines in case it doesn't get there. The board has a plan to use that money so to make sure that none of it goes back. The thing is, for instance, when the original guidelines were there, you had strict guidance on what staff could be used for. They had to be straight COVID related. And a little bit of that was the battle between, not a battle, but this philosophical thing between the city of Omaha and Douglas County in regards to what it could be used for. The governor made a tweak and a change that from March to June, money could be used for first responders. That's what allowed that money to be free and matched. Well, we did the same thing. That covered a certain amount of salaries, and that money is in the budget free. I need to know what that number is, because what your number is, so I can ask now for, like, say if you all need, because it's not going to be done by the end of the budget year in June. So if you need $3-4 million to do that, I need to start laying the stakes now for that money that has some flexibility. But even then, I don't want to lose this opportunity to talk to the public about what your role, the department's role is going to be after this, because there's no like ratcheting down back into what it was. I'm assuming that. So the flu vaccine, and this is just my reading, so I need the epidemiologist to take me there. This is my assumption. Flu vaccine, we got that in, that's there, but still, this vaccine for coronavirus, whenever it happens, is gonna be a choice every year. If don't enough people take it every year, you're gonna have this same deal of probably not as much, but you're still gonna have people catching it. I don't know what that is, but I just keep thinking the world and public health is not gonna be the same anymore. And we might as well get everybody used to, you're not gonna go back to what the budget was. There's gonna have to be some increase in something. And I don't wanna let that, people think it's just gonna go back there. And I think the state needs to understand that with the infrastructure that's set up for public health right now. So, you know, my deal is either you let the county, Douglas County, free on its own to be able to handle this, but don't keep us contained with 92 other counties that aren't at the same level. I just don't really want to be handicapped like we were now. There were instincts that you all had about wanting to do stuff, and we had to go beg the governor every time. And I don't want to be in that situation. So that's a long answer to it, but that's what my mind is.
We will provide you, bring forward some numbers, definitely, next time.
And the point of it is, quite frankly, too, the governor's gonna be turned down. The next person's gonna be the one that have to deal with this long-term deal. I mean, I don't think he's gonna have time to put it in. So, you need to kind of be putting this out there for whoever the next state CEO is gonna be. All right.
If no more questions, I'm going to have Justin Frederick talk about what's going on in epidemiology.
Morning.
Good morning.
See if we can get this up here.
And then hit that, where it says share on the right corner.
How do I find Justin? Can you get in there, Justin?
No. You know how to get my, no.
You shared your screen?
what I'm doing.
There's everything.
Bring
It's
that
a
up.
good picture. It's us.
Okay.
And you share your screen and she has to allow it. And
Are you running the presentation off your computer? Okay. Oh. You'll have to stop share and make him a co-host. So go to that little red square on the bottom there. This one? Yep. Then go over to your participants list and find Justin.
Well, it's,
Over here on the right.
Right, to the bottom.
Okay, then hit more. Then make co-host. Yes. And he should be able to share his screen. Yeah, that we live on Zoom.
Ta-da! There we go.
can you get on the left side of the screen there?
We'll figure this out yet. So again, good morning. Commissioner Rogers, you had a question about onset dates, and so I wanted to pull this up. This is our new dashboard, and onset dates, when we look at that, that's really an epi curve. So this is all of the cases that we've been able to do an investigation with and determine when they had onset of illness to give us a better idea of what's happening in the community regarding illness onsets, transmission, etc. So, but this is the new dashboard. I'll just show you here for a second, but not to get rabbit holed from what I'm supposed to be talking about. So this morning, I was asked to talk about the Epi response and what it takes. Every day you turn the news on, you hear about COVID, you see the numbers, you see Dr. Poor on TV or Dr. Ann or Keith or myself or Phil talking about this, but it really takes a tremendous amount of work, manpower, to come up with all these numbers, to do all the contact tracing, and I don't think people quite understand what that means. You know, we're over 20,000 cases and we're 8 months into this pandemic response. And I do appreciate Commissioner Rogers always looking out for us and the director looking out for us when it comes to our resources, because come the end of the CARES Act funding, if we don't have something in place, we are going to be in trouble, and I'll show you why here. So just a really quick overview, our Epi team at Douglas County Health Department, we're a small but mighty team. You know, we've done a lot of really great work here in Omaha, from detecting national outbreaks of hepatitis A to dealing with Ebola with the medical center and the biocontainment unit, to now working on COVID. There's about 8 of us. That includes, though, my boss, my division chief, myself, our senior Epi. We have 2 epidemiologists. We have 3 disease investigators. We're expanding capacity a little bit there, which is great news. A couple of public health nurses, and then we have our clerical support. And that's it. And if you think about that, and you think about 20,000 plus cases and almost 1 million laboratory reports that have come in for COVID, it's a small group of people to do all that work. We have been fortunate, though. We've used some of that CARES Act funding. And let me back up. I just wanted to clarify, this is just the Epi response. This does not include all of the rest of the folks in the department that are responding to COVID. You hear from Dr. Poor all about the call center. You hear about our health educators that are working with people who need assistance in rent or food, etc. Our lead staff, you know, this is really our STD staff. Everybody is really kind of pulled together and are responding to COVID at this time. Some of the CARES Act funding, though, we've used to hire some additional contact tracers, some temporary contact tracers, and we have about 16 of them that we've hired. great group of people. The majority of them we've been able to hire from the University of Nebraska Medical Center's College of Public Health or UNO's public health program. We've had a couple nursing students. What we found is that individuals with some sort of public health background or medical background really seem to do the best when it comes to contact tracing and understanding those recommendations, the disease, et cetera. We have been working with PRC. This is a state contract. We have currently 150 employees at PRC that are assisting us with contact tracing. So if you just look at the, yeah.
PRC does PRC do PRC
Yeah,
community health
yeah,
research?
that's correct, yeah.
And temporary, what's defined temporary? Are
So-
they 6-month employees?
No, temporary is defined as basically our CARES funding, so through the end of December. And I think the discussion that you were having earlier is a pertinent one about what we're going to do moving into the new year. So in total, just for the Epi response, the data, the contact tracing, et cetera, we have 176 roughly people that are working on that right now. And then I'm going to talk about different areas. I've kind of set up team leads and teams for each of these areas, including data and analysis, contact tracing, school surveillance, long-term care surveillance, and vital statistics. So I'm going to start with our data team. Our data team, again, small but mighty team. I have 2 epidemiologists that are leading this group, and then we have 3 temporary staff that have some sort of public health, epidemiology, or biostats background, or bioinformatics background. Like I said, we had a conversation on the phone the other day. I think we're pushing almost 1 million records, 1 million records for people who've been tested across the state of Nebraska. So that's a lot of data mining. We're talking big data. We're talking, I need somebody with really great expertise in programming, understanding bioinformatics, et cetera, right? And then all of that data that you see on the dashboard comes from all of this analysis. So what we're doing is we're taking all of that data, we're providing, those percent positives, the city council report for the mask mandate, 14-day report, our rolling averages, and then of course data cleanup. A big piece of that is also going in and identifying new cases every single day. So we run all of these labs that come in, all the positives and negatives, and we pull out all the positives, and then we have to deduplicate that data. A lot of people think that number of positives at 20,000, people are counted more than once. They're not. That's an individual. So you're only counted one time if you're positive for COVID. You're not counted multiple times. So to assure that our data is clean, we're constantly having to go through, deduplicate that data and make sure that we don't have people being counted more than once, that we're not interviewing them more than once. That's really difficult if you think about when somebody goes to the doctor and they put their name one way on their intake form. Maybe they go to Test Nebraska and they put it a different way, or they add a middle initial, or maybe they mess up on their date of birth, or the person who's entering that information into the system accidentally enters it wrong. We also are constantly supporting our contact tracers and making sure that we have quality data. I can guarantee you, we know this data forwards and backwards. We know the questions that we're asking. We're working with experts at the medical center when they're analyzing this data, in addition to us in public health. We're working with the state of Nebraska and how best to look at that data and additional questions to ask. And then all of that data we provide to the GIS folks here at Douglas County to put up on our dashboard. Our contact tracing team, I have one FTE that's really overseeing a lot of this contact tracing with the assistance of our temporary staff. And so of those 16 temporary staff I was telling you about earlier, 10 of them are dedicated strictly to contact tracing. The other 6 we've actually taken, and they're working on different areas of the response with us, and I'll talk more about that. But this is a big job. We've been working with PRC for many months since we've received the contract. We have weekly calls with them. We've provided training. And then there's actually a 2 o'clock call that the team has every single day with representatives from PRC and all of our contact tracers, where we try to identify common links. We talk about, if they have questions or different scenarios that have come up, or if the DHM has changed. So a lot of this information is constantly changing. Maybe CDC's changed recommendations regarding isolation quarantine, or you know, if you've had COVID and you've had another exposure, you don't need to be quarantined again for 90 days. You know, those sort of things. So we're constantly updating, making sure that our contact tracers are in the know with the most up-to-date information. We have an expectation that they complete a minimum of at least 4 investigations a day. I will tell you, many of them outperform this, you know, at least double or better each day. And then we are still trying to contact all of our cases within 24 hours of receiving a report. So I know that our resources are limited, and really with our contact tracers, I'm focusing on minors in our community. I want to make sure that we're identifying them and getting contact tracing done so that we can work with the schools. I'll talk about that here in a second. And then PRC, they're able to ramp up, I think, to 250 contact tracers. And as cases increase, they continue to bring on more staff to assist us as well. Once we do the contact tracing, all of those contacts then are entered into a system. And I don't know if you're familiar with Nelnet, which is a student loan service company. The state has actually contracted with them, and they're the ones that are contacting all of the contacts and notifying them of their exposure and the need to quarantine. So Team School, as I refer to them, you'll notice that we have 1 FTE, that's myself, and 2 temporary staff that are kind of leading this group. We've been working with the schools since probably June by participating in the MOAC, or the Metropolitan Omaha Educational Consortium meetings, which is made up of all the public schools throughout the metro, and their student services folks and lead nurses throughout the county. It's been an opportunity to be on the hot seat for an hour every other week for myself, but to answer questions about the best way to reopen, mitigation measures, the difference between isolation and quarantine, et cetera, et cetera. Through that, we also set up a system where the schools, because I quickly recognized that we were not going to have the manpower to do contact tracing in every single school and every single district across the metro. So we were able to work with each of the school districts and provide them with contact tracing. We actually made a video that is on our website right now. One of my public health nurses was able to put together. And we provided in-person training to each of those districts about how best to perform contact tracing within the schools and within the school districts. We also set up a REDCap survey so that schools can report to us any cases that they identify, and we report back to them any cases that we identify through contact tracing. So we're really closing that communication loop to make sure that we're all informed and identifying potential cases, so that if we need to do any sort of quarantine or self-monitoring.
On that data collection piece, like for instance with OPS with 90-some buildings, is that done at the building level or at the district level?
So I think it's in cooperation, but the reporting to us is actually done at the district level.
Okay.
Yeah. So with Lisa Utterbeck's group, and yeah. Again, we are on the phone a lot with schools regarding cases. Cases on sports teams is really it takes a lot of our time in identifying how best to move forward with isolation, quarantine, monitoring, and any additional mitigation measures. Long-term care, as Dr. Poore talked a little bit about this. We've been involved with the long-term care since the get-go. We have 1 staff member and 1 FTE and 1 temporary staff member, and I think that you'll notice throughout this presentation we're depending a lot on our temporary staff to assist us in this, right? So we actually are performing active surveillance for cases and clusters and outbreaks within these long-term care centers. They have a lot of questions about how to handle that, how to move forward, how to isolate, how do we get testing, how do we work with Test Nebraska. Now the Medicare, Medicaid, you know, they have testing requirements in place. So we're working with the state of Nebraska, and we've always been working with the ICAP team, the infection control and assessment group. They're a great group of infection control practitioners, and Dr. Ashraf, they've been great partners. And I think some of the data that was released earlier this week really shows the importance of the ICAP team. So then in addition to our Epi staff, we have our vital statistics staff. We have about 3 of them that are working on data as well. So they're working to identify and track all COVID-related deaths. And again, that means that COVID has to be listed on the death certificate for us to count that. I think there's a lot of confusion in the community about how we count those deaths. Daily analysis of that data that is up on the dashboard, where we're looking at it by a breakdown by age groups, race, ethnicity, whether or not they had any comorbidities, etc. Our rolling average, we're calculating several different ways. We have the 7-day rolling average per million population, and also by 100,000, which is also up on our dashboard. And then I think you're all familiar with the risk dial as well. So they're assisting in the analysis for that. And then hospital admissions, ventilator use from the OMHCC. And then our senior Epi, you guys are all familiar with our senior Epi. She's providing medical recommendations to the department and our response partners. I think one of her big roles as safety officer is for the Douglas County Unified Command. And then she's always playing a big role in data collection, how best to ask those questions, how best to analyze that data.
Justin, while you're there, explain to the board members that may not know the Unified Command and the Health Department role.
In the response?
Yeah, please explain to the members that may not know what Unified Command is.
If I have a better idea, honestly. Maybe.
Sure. So Unified Command, I'm at this time the incident commander for Unified Command, who meets twice a week. At this time, in the beginning it was every day. And that's people from law enforcement, emergency management, some of our staff internally, some of the police and fire that are from outside of Omaha in the smaller communities, they participate, and the sheriff's office, of course. And together, this team really tries to see what do we know from each other, what information do we need. Do we have a system called LifeLock, where people can put new information, new DHMs will be on there, anything that the team needs to know. So it really is a coordination that is going on. Right now we are saying what else needs to be done that could be helpful for this community. So this team also brings up issues. If they have seen, there have been a lot of gatherings that probably shouldn't have happened. So this team does trouble solving, but also collaboration amongst these different entities, and emergency management being there and really knowing where potential resources are in the community and how we need to look for it. So it's a good team, and it keeps us all together twice a week at this time.
Yeah, you just need, I just probably know, the thing about that too is, I think by law, elected officials don't allow to be in the meeting. So I think they give us briefings every so often. I don't think I've had one probably since April, but just to know because it's a health emergency, Dr. Ford is the tobacco chief. I'll start because I'm curious, the question you made about PRC, like they got 150 now, what's PRC's max of capacity if we get to a certain point? You said they go up to 250.
I think 250
Where they get their base from? Locally?
Yeah.
Okay.
Yeah. I do want to stress though that contact tracing is not as easy as everybody thinks, right? We've really learned that it takes some level of expertise, some knowledge of public health or healthcare to really do a good job at contact tracing. You have to understand, anatomy, physiology, virology, testing, all these things, to really, and then understand how the virus spreads and understand our community. So again, we're constantly working with that group of people to make sure that they're in the know. And then it's the data collection piece too, Good data in means good results out. Bad data in means bad results out. So, yeah.
So thinking about that temporary staff, so as the mass vaccination kind of rolls out, what do you foresee as like the staffing needs that's going to be related to contact tracing, especially since you have so much temporary staff? One, and two, how long is the contract with PRC? Does it end in December or does it go beyond that?
My understanding is that everything ends in December and is waiting for additional funding. But the contract with PRC is actually through DHHS, not through us. They've just been assigned to Douglas County to assist with our response. But yeah.
So then, what do you foresee for once mass vaccination does roll out? Is this contact tracing still going to be as necessary? Do you see that the amount of staff is going to change? And if it is, how much kind of? Because I know you don't know exactly.
Yeah, it's really hard to say. If we continue to see numbers going up, obviously we're going to need additional support in performing contact tracing. I think it's going to remain important throughout the pandemic, and even when we start to roll out vaccine. It's probably going to take 8 months to a year, right, before we have enough people vaccinated that we have good herd immunity. And so part of the response is going to continue to be able to identify, isolate, and break that chain of transmission within the community.
Thank you. That's what I'm.
Mm-hmm.
Justin, a while back I had heard some allegations. We were talking about death certificates and causes of death, but that hospitals may be including COVID as a reason or a cause of death because of acquiring extra funding. Was there any, hearing or seeing anything like that, or any hospitals having a greater number of cases?
No, nothing like that I'm aware of at all. And you hear stories about, if somebody died in a car accident and then they were tested for GoFit after the fact, it's a COVID-related death. That's not how this works. Really, COVID has to be one of the primary causes of death, and it has to be listed on the death certificate for us to count them. Yep. So we're very careful about who we're counting as a COVID-related death, and if anything, we're probably under-reporting. I mean, let's be honest. When you look at any of these communicable diseases, you're really looking at kind of the tip of the iceberg, right? Whether they're those that are being reported to us and those that we know about. There's always a certain amount of disease in the community that we're unaware of. And so I think that any expert would agree that across the country, we're probably under-reporting the deaths related to COVID.
Good.
Thanks.
Sunday, can you make sure, because I guess that report that the board gets. Okay. Thank you. We're going to item 7 and the department reports, if anybody's got questions. And I do, Carrie, I see you there. I got just one question for you. Or Dr. Ford may be able to answer if she's there. And it's just the grant that we got from the Kresge grant, so we got that. How long before we proceed for that person? I guess this is going to be the entryway for the equity officer for the time.
Well, partially. So you're asking about the Kresge grant. It was $49,000, I think, is that grant. There is still a lot of work that Andy is planning to do internally and also externally, bringing in, again, new individuals from across the nation who can actually prepare our community a little bit better in inclusivity, what does that mean, or so on. So it is the entry to that. I don't think we are there yet, yes.
I got the answer. Carrie, I'm good. All right. We'll go to any questions on any reports from any Seeing none, we'll go to item 8, G. Okay.
So we're continuing to work, with the equity team that was currently, or that was has been in place within the Department of Health, within the health department, and working to put together our committee. So we are in the process of collecting, names, or those that need to be nominated to be on the committee. If you recall, our charge has a limit of 9 people on the committee, however, we can have ad hoc participants. So I provided the board, with a list of names that have been nominated up to this date. And beginning in November, we'll start, reaching out and, determining the interest and making sure that there's a good fit within, that we hit all the things that we need to consider in regards to pulling this committee together. Also, there was just FYI, we had a conversation about, residency requirements for anybody that's on the committee. And so we've looked at, this is a Board of Health committee, and our requirements state that we have to be a Douglas County resident. So therefore, for the committee members, voting committee members, we're gonna maintain that standard that they have to be a Douglas County resident. However, our ad hoc members, can be non-Douglas County residents. They may work here, bring expertise that we need, so that gives us a little bit of flexibility there. Also, as we work to do this, we hope to have our first, formal meeting right after the first of the year. And the, committee meetings will occur on the same day as the Board of Health meetings. We've not determined a time, but on the same day. And then the last thing that we had a conversation about was, last month there was a resolution around the decriminalization of tobacco that was brought forward to the board. And we had some further conversation to help determine kind of what is the place of the board in this resolution, as well as what potentially could be the role of this committee in, considering future resolutions, similar resolutions. Specific to the decriminalization resolution, first of all, there was a deadline. It was a national, effort to get Board of Health, throughout the country to, basically state that this is an example of how racism can be interjected within policy, that these standards should be followed, etc. And just to say that it's basically a good idea. So the committee's going to, since we've missed that deadline of getting that resolution in formally, however, some of the recommendations that are in there are something that I think we should consider. We're gonna work through a different resolution that gives a little bit more clarity in regards to what is the role of the Board of Health. A lot of the recommendations that were within that white paper were more policy driven, from either the city perspective, county perspective, or even the state legislative perspective, that are beyond our powers. However, there are things that we can advocate for. So we'll work to clarify that resolution that clearly defines what the role of the board is in that white paper. Are there any questions about the committee?
I guess there's opportunity if there's a period now, if anybody sees any names that they want to add, they can do it now.
Correct, within the next week or so.
Okay. Okay, seeing no questions. We do have need for executive session for personnel and litigation. So with that, I'd like to ask for a motion to go into executive session for personnel litigation.
So
There's a motion by Wise, a second by Gray. Roll call.
Gray.
Yes.
Espinoza.